Good morning and welcome to Global Healthcast, brought to you by Global Health Press. In this series of broadcasts, we bring to you news on infectious diseases from around the globe once a week. I am Joe Schmitt, and with me is, as always, Dr. Melvin Sanicas. Good morning, Melvin.
Good morning, Professor Schmidt. Good morning, good afternoon, good evening, everyone, depending on where you are at the moment.
This is a very important day for mankind because as of today, humans on Earth will reach 8 billion in numbers. And along with this information, you can learn that there are more than 200,000 newborns every day, 9,000 per hour, 150 every minute. The vast majority of the growth comes from low and middle income countries, which are drivers for population growth. And this in Asia includes Pakistan, India, the Philippines, and in Africa, Egypt, Ethiopia, Nigeria, Tanzania, and Congo. So 9 billion will be reached in only 15 years. But then the 10 billion will only be reached 21 years later, as you can see from this graph. Germany, Japan, China, and Russia have decreasing populations, and they reduce a little bit the speed of the growth, and they will have to cope with aging societies very largely. The whole news, the big picture is more humans, more infectious disease. Older populations, more infectious diseases due to aging immune system, immunosenescence, and also due to comorbidities that result in more infections. Melvin, bad news for humans. We are too many. What do you think?
Well, I think this has been mentioned even decades ago, right? But it seems like the planet is still okay, I would assume. But it's indeed true that if you have more people, especially when they're living together, you will see that infectious diseases will spread faster, especially with um, a population that's not immune to it.
Yeah. Very interesting. So this is the message of today, or one of the important messages for the day, and this will keep us busy for many years, I guess, to think about what to do with this. But Melvin, the important thing is to really learn about our COVID-19 update, deaths due to COVID-19 in children and young people, antibodies and effectiveness, third and fourth booster effectiveness in Thailand, monkeypox, and COVID-19 incidents and masking policies. These are the topics today. And again, as always, we really start with your update on COVID.
Yes, so for those who have been watching our Global Health Cast, you already know this, that we start with this global COVID epi update from the WHO. And again, we always say every week that this is not real time. This is actually at least a week late. The number of weekly cases decreased by 15% last week as compared to the previous week. And the number of new weekly deaths also decreased by 10% as compared to the previous week. And as of last week, 6th of November, there have been 629 million confirmed cases and over 6.5 million deaths reported globally.
This is important new data. So numbers are declining overall. My impression is they are not declining, at least here in Germany, but I may be totally wrong. It is just my impression from what I hear from colleagues in intensive care. Yeah, what is any thoughts? I mean, deaths is a hard number, right? You cannot, this is really decreasing, and that's the good news. But what about my impression? Do you really think numbers are going down, or how could one explain that intensive care units are really full?
Well, we have not seen really robust data studying this, but there have been reports in the US and in Europe of hospitals now being overwhelmed with severe influenza or severe RSV. And the cases are much more than COVID. So that could be one explanation.
Actually, we talked about that months ago, and the story is really nicely shown in this picture. Can you explain this? What does these mean? All these blue and red lines here and areas?
So on top, you see cases of endemic viral illness in children, right? And in the previous Global Health Cast, you've shown that many viruses can cause acute respiratory illnesses in children. And you see here the numbers in blue, or is it blue green? and and this peaks every winter time. 2008 you see it, 2019, 2020 you see it. And because of the control period where almost everyone was asked to stay at home, you see that there was this gray zone where the number of respiratory illnesses in children completely disappeared. And then after that, you now see it going up again. And then you also see it going up in older children in red. And it can be explained. There are many explanations, but one can explain by saying, of course, that every year there are new babies born. So when you say when you say new babies, new children, they are actually not immune to influenza. They have not experienced this before, and that is the cohort that can truly be at risk of infection. And as you mentioned in the previous slide, of the 8 billion people in the world, there are 216 new babies every year. And we have just been talking for 4 minutes now. And every minute you have 150 babies born, right, in the countries that you've mentioned. So these new babies who are not at risk, who are at risk, sorry, of getting infected, are adding to the population. So that is the reason why every year new at-risk population are included in the whole total population of a community or the world.
So basically, the story is the balance between new infections, which you see on the top, and the more susceptible newborns coming into the population who are at risk for infection for the next season to come.
Mm-hmm.
And some older children, as shown in red here, they did not catch the disease, so they will be only infected a year later. And this is what we said a couple of months ago. This is what we may see, that there's a huge increase in numbers, right? And the intensive care units may be filled because it's not COVID, but other infectious diseases that we did not see here in 2020, 2021.
Yeah, or it's also possible that these people have any of these respiratory illnesses and COVID.
Okay. Yeah. So this is a very nice graph, and yeah, I think this is important information, and this is what we may be seeing now. Yeah. Melvin, you have more news on COVID deaths per million people.
Yeah, so I think this is something that's giving us some hope, giving us reason to be cautiously optimistic. The WHO reported a nearly 90% drop in recent COVID deaths globally compared to several months ago. But of course, they still urge vigilance against the new variants coming up because, as you know, we are hearing about the variants that we discussed in the previous Global Health Cast. So last week, over 9,000 deaths were linked to the coronavirus. And in February in 2021, um, there were 75,000 deaths globally in just 1 week. So if you look at February 2021 to now, I think we have come a long way, and this can probably be explained by vaccination, by immunity from infection from the SARS-CoV-2, from better treatments, from a lot of things that we know now about COVID as compared to 2021, early 2021.
Interesting information. Overall, good news that we are now with quite low death toll, although 10,000 deaths a week is really quite a lot, right? This is difficult to accept for a disease that is treatable. I mean, we do have medications today and we have means for prevention. So this is sort of difficult to accept. Is there more data? I think you have more data on this from England, right?
Um, yes, this is actually a study from England looking at COVID-19 deaths in children and young people. So they use the abbreviation CYP, children and young people. We know that deaths due to COVID-19 in children and young people is rare, but there are very few population-based studies on infection fatality rates in this population, especially with COVID. The study basically linked many national data sets to identify all children and young people aged 20 years and below who died within 100 days of a positive SARS-CoV-2 test in England. And what they found was that approximately 75% had significant underlying health conditions, mainly severe neurodisability and immunocompromising conditions, or those children who are taking drugs to control their overactive immune system. And what this study found is that deaths due to COVID are actually quite low in children and young people, even with the emergence of new SARS-CoV-2 variants. And most of these deaths occurred really in children and young people with underlying health conditions.
So the big question is how to protect those.
Yeah.
How does society deal with those who are vulnerable?
Mhm.
And still, I propose to wear a mask. And I
Yes.
still propose to get your vaccine, even if you are at low risk. But it is just with respect to those who may die. This
Yeah.
would be my take from this, right?
Yes, I agree because for these people, especially the ones with immunocompromising conditions, even if you boost them again, the chances of them really developing immunity is still quite low. And we've seen this in adults as well, right? That even if you give them the fourth dose, it's not as good as people with functional immune system.
Yeah.
So masking is really a very simple way to do that. And we have been doing this for over 2 years now. And the argument that people are still finding masking, difficult or not comfortable, I think is a bit ignorant.
Yeah. Very interesting information. I have some new data on anti-COVID antibodies and effectiveness, and this is data from Israel on people who have received second, third, fourth doses of the Pfizer BioNTech vaccine. And what you see here on the left side is IgG antibodies, which is ELISA antibodies, after second, third, and fourth dose, shown here in different colors. And you see here how titers go down a little bit with time, and they increase with per vaccine dose. Second dose, third dose, fourth dose. They always get a little bit higher. Neutralizing antibodies, likewise, this is second dose, this is third dose, and this is fourth dose. And again, with time, these titers decline. The nice thing from this study from Israel is that they looked into effectiveness, which is 1 minus hazard ratio. And which means if the hazard ratio is 1, the vaccine does not work. And this down here means days after day 7 to 35 after the fourth dose, effectiveness is roughly 50%, between 40 and whatever, 55%. And then 36 to 102 days after the fourth dose, effectiveness goes down to 40%. And if you take the time period after 3 months to 181 days, there is no effectiveness of the vaccine. And here you see the whole period. If you look at the whole period as one, which is then a combination of all the data. Very interesting. For me, the main point is looking at antibodies, and it indicates even if antibodies are present, you may not be well protected. That is one of my main stories that I always try to tell. Immunity and protection are two different things. You may be immune and you're still not protected, and you may have no immunity, no detectable antibodies, and you're still protected. We know from other sets of data that even if in the absence of antibodies, there may be T cells circulating and you may still have protection from vaccination. So always be sure if people tell you about immunity or protection and they don't well go together. That's my main take from that publication from the New England Journal of Medicine, actually. Melvin, any thoughts on this or any comments?
I think this actually is a good segue to the next slide, which is really looking at the heterologous third and fourth dose vaccines given. And this is a study from Thailand. And basically, a quick summary of this study is that the third COVID vaccine dose reduced the risk of severe COVID, even with the Omicron, and optimal protection was seen with the third dose given at least 2 weeks before a positive, being infected with COVID, and that in the population in Thailand, so they received many different vaccines, unlike in Europe or the US, where most vaccines were just the Pfizer BioNTech or the Moderna vaccine, right? In Thailand, they were given boosters with either the Pfizer BioNTech vaccine, the AstraZeneca vaccine, or the Moderna vaccine. And in this study, at least from Thailand, it showed that all these three different boosters given to all the different vaccines that they were given um, as first two primary vaccination doses, they offered similar protection.
Yeah. So I'm not quite sure. Is the message that you should receive the third dose just before you get infected? I mean, ideally, you get your dose just before you are, 2 weeks before you are exposed, right?
Yes, I mean,
Um,
yes, it's basically saying that you get your booster as soon as you can, just because it takes at least 2 weeks for you to be optimally protected.
right.
So
Yeah. Yeah. Yeah, which is again, immunity kicks in after, if it is a booster dose, after 3 to 7 days. So I guess at 2 weeks you have optimal immunity and optimal protection as well, right? You get highest titers probably after 2, 3 weeks if it is a booster. Actually, titers start increasing at day 3 to 7. So
mhm.
very interesting. Let's switch to monkeypox. And what you see here is a nice summary of the transmission of and the differences about old classical monkeypox and new emerging monkeypox in the Western world. Initially, the reservoir host for monkeypox virus is squirrels and rats living in the rainforests. Sometimes monkeys or African apes are infected. In the end, due to the proximity of living of these reservoir hosts with humans in villages and towns, humans are infected and they give the infection to other humans. And due to global travel and due to global contact, global populations may be infected. At the same time, monkeypox may be transmitted by apes and monkeys through selling these animals and bringing them to different populations around the globe. And then now infected prairie dogs may be a reservoir that may infect young adults and children, for example, in the United States. Quite complex story, but you nicely see here in this graph the differences between the two cycles of transmission. And this table summarizes the classic form and the new clinical epidemiological form. The classical form is seen in Central and West Africa. Today, we see monkeypox in Europe, North and South America, Middle East, and Australia. The affected population initially was children and young adults. Now, the main human disease, the bulk of human disease is seen in young men who have sex with young men, as they have multiple partners over short periods of time, and we had reported out that in the past. In the past, we saw sporadic cases only from the reservoirs jumping to humans. Now we see a pandemic underway since May. The transmission here is due to infected reservoir animals, and now it is exclusively in the Western world human-to-human transmission. Dissemination was initially mostly intrafamilial with close contact, And now we see it mostly among sexually networking young men who have condomless sex with multiple male partners. The incubation period, and this really was this was followed by prodromal stage, eruption phase with skin lesions. And now this is a little bit different where we see the eruption phase with lesions in an unusual distribution, especially at the genitals. This is where the virus is then transmitted from human to human. The symptoms were initially in the old form, lesions on the face and extremities and centrifugal distribution, and now again it starts in the genital areas. The viruses are a little bit different. It used to be the Central African and West African clades 1 and 2, and now it is the West African variant clade 3. Case fatality due to lack of medical attention and medical care used to be 1 to 15%, and now with appropriate care, it is really, really very low. Only rarely someone dies in the Western world from monkeypox. This is a nice summary of the differences. Melvin, is this clear, or any questions or remarks on this?
Yeah, I think it clearly summarizes the main difference between the classical form from the 1970s to as compared to what is happening now. Because I mean, initially we were saying that because it's spreading, and if this is like the case in Central and West Africa, we would expect many people to suffer and have serious monkeypox or even die, and it seems to be not the case. So it's a good thing.
Yeah, actually, numbers are declining. So this is the overall very good news. I have one last topic today, which is wearing masks. And Melvin, you will like this. These three graphs show you among staff, students, and combined students and staff, the number of weekly COVID-19 cases per 1,000. And what is separated here is district that sustained masking and those that lifted masking in a period that is shown roughly here in the middle between March and April. This is where you see the difference here. And what you can see nicely, the difference between those counties that sustained masking, the case numbers is really staying low, whereas in those that lifted masking, it is more than twice as high, right? And you see this here in combined, you see it for students only, and you see it for staff only. So masks are working. If you were not convinced, this is another line of evidence. Wear your mask when you meet others, particularly those that are vulnerable. And Melvin, any thoughts on this one?
I'm actually happy, at least here in Switzerland, I still see some people wearing masks. Of course, majority of people are not wearing masks, but I still see one or two people inside the trams, for example, or in trains, that they feel that they want some extra protection and they're wearing masks. And of course, most of these people are older adults, but I also see younger adults who are wearing masks, even though it is not mandated or not required.
You were in China, I believe, or Singapore recently, and to my experiences, people have been wearing masks even long before COVID, right? Due to flu,
Yes.
whatever, they were always wearing a mask, or
In
many of them, and
Asia,
it
that
was
is common. Yeah, people
very
just
common
wear
there.
masks if they want to wear a mask.
Yeah, yeah. Yeah, maybe we should accept this as a better culture than our acceptance, our low acceptance for masks, and maybe we should wear the mask more often, particularly with regard to being respectful to those who are vulnerable for infectious diseases.
Exactly.
Let's summarize what we learned today. The human population today will grow to 8 billion. We don't know when and where number 8 billion is born, but it will happen today. That is what researchers tell us. Number and deaths due to COVID decline. Melvin showed you that death due to COVID-19 in young children is really rare, and those who die have underlying diseases. And we discussed that due to respect for those with underlying diseases, it is still a good idea to get the vaccine and to wear a mask. I showed you that antibodies decline after the fourth dose of mRNA vaccine in this example. and that also protection declines even if antibodies are still present. And again, there is a difference between immunity and protection. Melvin explained the third and fourth dose of and effective vaccine effectiveness in Thailand. We showed you the difference between monkeypox classical and the new pandemic monkeypox, which is quite different from clinical aspects and also from virology. And finally, we showed you that COVID-19 incidences are lower if people are wearing masks. With that, Melvin, you have a nice cartoon in the end of our presentation today.
Yes, something not related to science, just a reminder for everyone that I think, we have to be aware that we see the world not as it is, but really as how we have been conditioned to see it, or as ourselves, because we have different experiences, education, our fears and our dreams, our hopes, and even our strengths and weaknesses, and all these things actually shape how we see the world. And it's just, maybe if we are all aware of this, or we remind ourselves that we see the world as we are and not as what it is, it can maybe probably make the world a better place when we think about it and not force our views onto other people.
Melvin, I totally agree. And I even think that a scientist has a very unique and individual way to look at the world. If you're an immunologist, you look at titers. If you're an
Mhm.
epidemiologist, you look at protection. And we have to combine this, right? The art of science is really combining different views and, coming up with a new picture. And I think this is a nice closure of our meeting. This was our 20th Global Healthcast. And I'm Joe Schmitt, and I'm very happy that for the 20th time with me was Melvin Sanicas. Goodbye, Melvin.
Thank you very much, everyone. Thank you, Professor Schmidt, and see you again next time.